An infant presented with erythematous lesion on cheek extensor aspect of limbs. Mother has history of bronchial asthma. The probable diagnosis is airborne contact dermatitis. A 3-month-old infant is having thick scale on scalp with dandruff. Erythematous scaly lesions on the nasolabial fold are also present. The diagnosis is seborrheic dermatitis. A 24 years male has eczematous dermatitis involving scalp and face with greasy yellow scale. He is also suffering from severe dandruff. He is having seborrheic dermatitis. A 3-year-old child has eczematous dermatitis on extensor surfaces. His mother has a history of bronchial asthma. Diagnosis should be atopic dermatitis. A 25-year-old man present with recurrent episode of flexural eczema, contact urticaria, recurrent skin infection and severe abdominal cramp and diarrhea upon taking the seafood. He is suffering from atopic dermatitis. Rakesh, a 7-year-old boy, had itchy excoriated papules on the forehead and the exposed parts of the arms and legs for 3 years. The disease was most severe in the rainy season and improved completely in winter. The most likely diagnosis is insect bite hypersensitivity. Seborrheic dermatitis is frequently seen in Parkinson's disease. Spongiosis is seen in acute eczema. Characteristic feature of atopic dermatitis is pruritus. Itch is disease is true for atopic dermatitis. Denny Morgan fold is seen in atopic dermatitis. Most common site of atopic dermatitis, antecubital fossa. Atopic dermatitis is diagnosed by clinical examination. Minor clinical feature in diagnosis of atopic dermatitis, all except pruritus. So, minor clinical features are dry skin, Morganian fold, Bitariasis alba, and dermographism. Pruritus is a major clinical feature of atopic dermatitis. Of true about atopic dermatitis are all except. So, Mica-like scale is not true. What is true is pruritus, scratching, and xerosis. In India, the plant which causes dermatitis most commonly is Parthenium grass. Most common cause of airborne dermatitis in India is Parthenium. Most common cause of allergic contact dermatitis in Indian female is none of these. Most common precipitant of contact dermatitis is nickel. Patch test is read after 2 days. Patch testing is done for allergic contact dermatitis. Airborne contact dermatitis can be diagnosed by patch test. Patch test is done to document delayed type hypersensitivity. A 55-year-old male with uncontrolled diabetes, mellitus, and hypertension developed severe airborne contact dermatitis. The most appropriate drug for his treatment would be azathioprine. Coin-shaped eczema is nummular eczema. Exfoliative dermatitis can be due to all of the following diseases except Bitariasis Rosacea. So, exfoliative dermatitis can be due to drug hypersensitivity, Bitariasis rubra pilaris, and psoriasis. Causes of erythroderma is psoriasis, lichen planus, and eczema. Gold poisoning lead to exfoliative dermatitis is treated by steroid. All may lead to hives and wheals except the typhoid fever. So, cold, hepatitis C, and serum sickness can lead to wheals and hives. A patient gets recurrent urticaria while doing exercise and on exposure to sunlight. Which of the following is most likely cause? Cholinergic urticaria. A 22-year-old woman developed small itchy wheals after physical exertion, walking in the sun, eating hot spicy food, and when she was angry. The most likely diagnosis is cholinergic urticaria. Following is a type of physical urticaria. Dermographism is a type of physical urticaria. Urticarial lesions are best described as evanescent. A 5-year-old male child has multiple hyperpigmented macules over the trunk. On rubbing the lesion with the rounded end of a pen, he developed urticarial wheal confined to the border of the lesion. The most likely diagnosis is urticaria pigmentosa. A 9-year-old has multiple itchy erythematous wheals all over the body for 2 days. There is no respiratory difficulty, which is the best treatment, antihistamines. All are true regarding hereditary angioedema except dysfunction of enzyme is most common cause, that is not true, and bradykinin level decrease during attack is also not true. What is true is enzyme involved is CLINH and chlorine inhibitor targets Hegman factor. and complement C4 and C2 decrease. A man takes peanut and develops tongue swelling, neck swelling, stridor, hoarseness of voice. What is the probable diagnosis? Angioneurotic edema. A patient presents with a history of episodic painful edema of face and larynx. Which of the following is likely to be deficient? C1 esterase inhibitor. Or a person present with recurrent swelling on face and lips due to emotional stress. Cause is chlorine esterase inhibitor deficiency, C1 esterase inhibitor deficiency. Immediately after eating, a man develops swelling of face and lips, respiratory distress, intense pruritus, hypertension, and feeling of impending doom. The most likely diagnosis is anaphylaxis. Not true about angioneurotic edema, pitting edema of face, lips, and mucous membrane. That is not true. What is true is C1 esterase inhibitor deficiency can cause it, extreme temperature exposure can provoke it, and known with ACE inhibitor. Now, papillosquamous disorder, all are cause of papillosquamous lesions except congenital syphilis. So, the causes of papillosquamous lesions are psoriasis, parapsoriasis, squamous cell carcinoma, and mycosis fungoides. All of the following may lead to plaque formation except pemphigus. So, in psoriasis, lichen planus, and Bitariasis rosacea, plaque formation can be there. The important feature of psoriasis is scaling. A 30-year-old male presented with silvery scales on elbow and knee that bleed on removal. The probable diagnosis is psoriasis. A male is presenting with a violaceous papule which is pruritic. There is a pterygium of nail with cicatricial alopecia. The diagnosis is lichen planus. 10 years old child has violaceous papule and pterygium of nail. The diagnosis is lichen planus. An adult is presenting with severe dandruff and greasy yellow scale on the scalp. The diagnosis is seborrheic dermatitis. A child is presenting with erythematous follicular papule on the trunk. There are areas of normal skin within the lesions. There is thickening of palm and sole. The child is suffering from Bitariasis rubra pilaris. A patient presented with scarring alopecia, thin nail, hypopigmented macular lesions over the trunk and oral mucosa. The diagnosis is none of these. A young female presented with loosey linear lesions on tongue since a month with elongation of nail fold beyond the nail bed. What is the diagnosis? Lichen planus. Multiple erythematous annular lesion with peripheral colorate of scales arranged predominantly on trunk are seen in Bitariasis rosacea. A 16-year-old boy presented with asymptomatic multiple erythematous annular lesion with a collarate of scales at periphery of the lesions present on the trunk. The most likely diagnosis is Bitariasis rosacea. Which of the following seen in psoriasis? Micromunro abscess, hyperkeratosis, and suprapapillary thinning. All are true about psoriasis except very pruritic. So what is true is pitting of nail, joint involvement in 5 to 10%, parakeratosis and acanthosis, and Munro abscess. Typical silvery scale of psoriasis are absent in groin. Least common site of involvement in psoriasis is CNS. Involvement is least common. All are true regarding psoriasis except head, neck, and face are not involved. So what is true is arthritis in 5%, abscess is seen, and no scaly red lesion are seen in inflammatory and inframammary and natal area. A patient presents with erythematous scaly lesions on extensor aspect of elbow and knee. The clinical diagnosis is got by Osped sign. Most common type of psoriasis is plaque psoriasis and psoriasis vulgaris. This type of psoriasis is commonly seen in children and may follow a streptococcal sore throat, guttate psoriasis. Psoriasis associated with beta hemolytic streptococcal infection, guttate psoriasis. Normal healthy child developing psoriatic lesion after an episode of streptococcal infection. Which type of lesion is this? Guttate psoriasis. Ospid sign is characteristically seen in plaque psoriasis. A patient with psoriasis was started on systemic steroid. After stopping the treatment, patient developed universally red scaly skin with plaque losing their margin all over the body. The most likely cause is erythrodermic psoriasis. A patient with psoriasis was started on systemic steroid. After stopping treatment, the patient developed generalized pustules all over the body. The cause is most likely to be pustular psoriasis. Monro microabscess is seen in stratum corneum. About micromonro abscess, which of the following statement are true? It is seen in stratum corneum, it is seen in psoriasis, and it contains neutrophil only. Bleeding spot seen on removal of scale is in psoriasis is called as Auspit sign. Auspit sign is related to psoriasis. All of the following are seen in psoriasis except it is pre-malignant disease. That is wrong. What is true is Auspit sign is present. 10% are associated with arthritis and worsening of disease during winter. Psoriasis is characterized by all except always associated with nail infection is not true. There is definite pink plaque with clear margin in children, disappear in 2 weeks to reappear again, and involves knee and elbow. Treatment of psoriasis is PUVA and methotrexate. Vitamin D analog calcitriol is useful in the treatment of psoriasis. Treatment of pustular psoriasis is retinoids. Treatment of choice in pustular psoriasis, systemic steroid. Drug of choice for a pregnant woman in second trimester with pustular psoriasis is prednisolone. The treatment of choice for erythrodermic psoriasis is methotrexate. A primigravida female presented with erythematous skin changes and lesion with multiple pus lake. Which of the following should be the most appropriate? Corticosteroid. Drug of choice for impetigo herpetiformis is prednisolone. The only indication of giving corticosteroid in pustular psoriasis is psoriatic erythroderma with pregnancy. The only definitive indication of systemic steroid in psoriasis, impetigo herpetiformis. Psoriasis is exacerbated by all of these: lithium, beta blocker, and antimalarial. All of the following drug can worsen psoriatic lesion except acitretin. Chloroquine, beta blocker, and lithium can worsen the psoriatic lesion. Treatment of psoriasis include all except oral corticosteroids. So it includes retinoid, methotrexate, and cyclosporin. Itchy polygonal violaceous papules are seen in Lichen Planus. Itchy purple papule followed by hyperpigmentation on resolution is seen in Lichen Planus. Not a histological feature of Lichen Planus. So neutrophil in stratum is not a histological feature. There will be acanthosis, hyperkeratosis, and pigment incontinence. The most characteristic finding in Lichen Planus is basal cell degeneration. The basal cell degeneration is seen in Lichen Planus. Max Joseph space is a histopathological feature of Lichen Planus. Wickham stria is seen in Lichen Planus. Most characteristic feature of Lichen Planus is Wickham stria. Characteristic nail finding in Lichen Planus is pterygium. Lacy white lesion in mouth with pterygium seen in Lichen Planus. A young lady with white lacy lesions in oral cavity and her proximal nail fold has extended onto the nail bed. What is the likely diagnosis? Lichen Planus. Regarding Lichen Planus, all are true except hypopigmentation and residual disease is not true. Lymphatic infiltration in supradermal layer, itchy polygonal purple papule, skin, hair, and oral mucosa commonly involved. What is true about Lichen Planus? There will be basal cell degeneration, colloid body seen, epidermal hyperplasia in chronic cases, Wickham stria is seen, and it is an autoimmune disease. Cicatrizing alopecia with perifollicular blue-gray patches is most common associated with whitish lesion in the buccal mucosa. Civate bodies are found in Lichen Planus.